morning. My name is Greg Kennedy. I'm a colorectal surgeon here at the University of Alabama in Birmingham. And today, what I'd like to talk to you about is the logical approach to benign anorectal disease. The reason I've chosen this talk to bring to you all is largely because I think these diseases, hemorrhoids, Fissure-in-Ano, Cryptoglandular Disease, Pilonidal Disease, are largely a black box to many practitioners. So what I'd like to do today is just try to shed a little light on these areas and put them in a context that's very easy, I think, to manage, give you some algorithms, some fairly straightforward algorithms to think about the problems. I'm going to give you just a little bit of background on each disease, but primarily just get right into treatment. So hemorrhoids, as you all know, these are normal parts of the anatomy. They're cushions of specialized, highly vascular tissue within the anal canal in the submucosal space. And in general, there are three main cushions in patients: left lateral, right anterior, right posterior. But it's actually only present, they're only present in this configuration about 20% of the time. It's important to know that these really are normal parts of the anatomy. So everyone has hemorrhoids. And they become a problem when they're problematic, when they're symptomatic. The prevalence of symptoms really will peak between the ages of 45 and 65, and of course they're more common in affluent whites. They're classified as both internal and external, with external hemorrhoids being located in the distal 1/3 of the anal canal, and internal hemorrhoids are classified really according to the degree of prolapse. We're going to talk about both internal and external, and first, just to talk about external, there's somewhat of a conundrum. I see patients all the time sent to me with symptoms or with the diagnosis of external hemorrhoids. And by and large, their symptoms are a result of poor anal hygiene, things like itching, burning, things like that. Thrombosis, of course, like you see here on the slide, this is a painful situation. These patients, it's not a difficult diagnosis to make. These patients are in extreme pain. They don't want to sit down. The onset of pain is relatively sudden. Internal hemorrhoids, on the other hand, are classified by degree of prolapse. First degree of prolapse, there's a bulge in the lumen of the anal canal, and sometimes painless bleeding. Second degree, there's a protrusion at the time of a bowel movement with spontaneous reduction. Third degree, there's protrusion at the time of bowel movement, and the reduction has to be assisted. Fourth degree, there's a protrusion at all times, and they cannot be reduced. The symptoms vary according to the degree. Painless bleeding with first degree. Second degree, you have some painless bleeding. You feel an anal mass with defecation. Patients can get some burning and itching. Third degree, those symptoms are just magnified. Fourth degree, of course, there's a fair amount of symptoms of poor anal hygiene, fecal leakage. Signs, of course, first degree, you have bright red bleeding. Second degree, you see the prolapse with defecation. Third degree, you'll see prolapse with defecation, and it may be present even after defecation if the patient hasn't reduced. And fourth degree, when you look at their bottom, they'll be present there. The treatment for symptomatic internal hemorrhoids, the largest the patient population I've seen come in with either first or second degree. Dietary and lifestyle modification is the most important management here. This is increased fiber in the diet, weight loss, increased activity. Some non-operative offers procedures as well, things like hemorrhoid banding, and then of course we can always get into operative hemorrhoidectomy. Again, I really treat based on degree. First degree without prolapse, dietary modification, encourage weight loss, encourage activity, perhaps some banding if the patients are having a fair amount of bleeding. With second degree, we can think about some banding. Infrared sclerotherapy and infrared coagulation, to be honest, I have that there for historical reference only. It's really not used by and large. Banding, recurrent banding may require some type of surgical therapy as well. With third degree, you really move into the area of hemorrhoidectomy. Banding really doesn't work that well with these patients. You can certainly try it. You can do recurrent banding over time, have patients, or sequential banding over time, have patients come in over and over for sequential banding. I've also got on here straightforward hemorrhoidectomy, and then a couple of newer procedures, procedure for prolapse hemorrhoids or a stapled hemorrhoidectomy, and that's transanal hemorrhoidal dearterialization, or THD. For fourth degree, this is where prolapse is out and is not reducible. Hemorrhoidectomy is the standard treatment. PPH and THD are slightly more controversial. Banding is an office procedure, fairly straightforward, done with little to no sedation. It can certainly be done in the office if the patient has the proper anatomy. Remember that the tissue distal to the dentate line, that line that demarcates our transition from columnar and the anal transition zone, so for columnar mucosa into squamous cell mucosa, that dentate line tissue distal to it is innervated. Tissue proximal is not innervated. So you can really put your band proximal to that dentate line without any negative ramifications to the patient. This is done with anoscopy and either a suction bander or a bander where you grab the tissue and pull it into the rubber band. Hemorrhoidectomy, operative hemorrhoidectomy, this of course requires an anesthetic of some type, either a general or regional anesthetic, and it requires the surgeon to resect the entire hemorrhoid tissue and then close up the defect if you're performing a Ferguson hemorrhoidectomy. There are other hemorrhoidectomies where the defect is left open. And then of course, stapled hemorrhoidopexy is a procedure whereby you capture tissue that's prolapsing into this end-to-end stapling device, and then you fire the stapler, removing a ring of tissue and really pulling those hemorrhoids back up into the anal canal. So in this case, you're not really removing hemorrhoid tissue, but you're removing redundant mucosa. So it's really a hemorrhoidopexy is what it's called. Dearterialization works using a small Doppler probe on the end of a modified anoscope. You find the hemorrhoidal arteries that are feeding the vessels, and then using suture ligation, you actually ligate those hemorrhoidal vessels. And then as you run that suture down the mucosa, and then there's a pexy procedure where you actually tie your suture back up to the top of this hemorrhoidal vessel, really pexing, so both devascularizing and pexy the hemorrhoid back up into the anal canal to both devascularize and also eliminate the prolapse. Complications of treatment, of course, specific to the technique. Incontinence is what we worry the most about. It's important to realize that hemorrhoids may provide up to 20% of the anal resting pressure. That's really why we don't want to surgically remove hemorrhoids that aren't symptomatic in general. So this is really a problem that I tell patients, if we're going to treat your hemorrhoids, it really should be a life-altering treatment. That is, we're taking you from a situation where you really can't stand the hemorrhoids anymore to a point where now your life is back to normal afterwards. Fissure-in-Ano just warrants a brief discussion. The hallmark symptom, if you've seen patients, is pain during and after defecation. They'll often say it feels like they're passing razor blades. Bleeding is minimal, usually limited to bright red blood seen on the toilet paper. On physical exam, you'll classically see the fissure in the posterior side of the anal canal. There may be a hypertrophied anal papilla or a sentinel pile associated with that fissure. In general, the location of the fissure indicates the cause. Anterior and posterior in the anal canal, these are acute and chronic anal fissures. A chronic anal fissure is really defined as a fissure that's been present for more than 3 months. If you start seeing multiple anal fissures or fissures in the lateral locations, you have to at least think about other causes. Crohn's disease, ulcerative colitis, syphilis, TB, leukemia, cancer, HIV, all of these patients can develop fissures. If multiple anal fissures in the lateral locations, at least should bring to mind a possibility of a cause other than acute and chronic anal fissure. Remember, 90% of our fissures, or 80% of our fissures, are posterior, 10% are anterior. The other 10% are sporadic. The vast majority are caused just by trauma, but we do have to think of these other disease processes in situations where it doesn't quite make sense. Management, conservative management, almost half will heal with conservative measures. Fiber, sitz baths, topical anesthetics. I tell patients to increase their fiber. If patients will increase their fiber to more than 30 grams of fiber a day, fissures will heal. The majority of them will just heal. We also encourage patients to think about some medical therapy, sphincter relaxants, nitroglycerin, calcium channel blockers. Success rates are 20 to 100% with very short follow-up depending on who you read. In general, I'll say about half of patients is what I tell my patients. About half will heal with conservative management and medical therapy. The other half will need some type of surgical intervention. Botulinum toxin or Botox injection has been utilized. There's randomized controlled trials available of Botox versus nitroglycerin. Your healing rates in that trial were higher in the Botox, but however, recurrence was high in both arms. So Botox is more effective in the short term, but this requires some dietary modification to maintain healing over the long term. Lateral internal sphincterotomy is by far the gold standard. A recent randomized controlled trial published out of the Toronto group demonstrated that lateral internal sphincterotomy versus medical therapy is much more effective and safe. 100% healing in the lateral internal sphincterotomy group versus about 40%, recurrence of 0 versus 40% at 6-year follow-ups. Rates of incontinence were no difference in either arm. In general, this is the algorithm that I'll use for a sporadic anal fissure. If it's truly sporadic, I'll treat patients with conservative therapy, fiber, sitz-baths, diltiazem, or nitroglycerin, nifedipine ointment, something like that. And I'll try this for at least 6 weeks of therapy. If they fail, I may try to go back to having them increase more fiber. In general, patients aren't terribly reliable with their fiber treatment, so I'll have a further conversation. If they're in too much pain or if they've really failed and they want to move on, I'll consider Botox. Honestly, since the publication of the randomized controlled trial out of Toronto, if the fissure's been present for longer than 3 months, I may just go right to lateral internal sphincterotomy and pass Botox. Botox, in my experience, has been a fairly high failure rate. So I've sort of taken that out of my personal armamentarium. However, it's not an unreasonable option to move to Botox injection. Cryptoglandular disease, this is anorectal abscesses. It warrants just a brief discussion. 90% result from nonspecific infection, cryptoglandular infection, obstruction of the anal glands and ducts, stasis, infection, formation of an abscess. Predisposing factor is diarrhea and trauma. Bad luck as much as anything. Location in their potential anal rectal space, it's important to think about this as we consider treatment. Ischiorectal abscess is outside of the sphincter complex and is really out in that ischiorectal fat. A perianal abscess is also in that fat, but it's really right next to the anus itself. Intersphincteric is between the internal and external, so the internal sphincters and the external sphincter muscles. Remember, our external sphincters are a continuation of the pelvic floor. Internal sphincters are really a continuation of the internal muscle layers of the rectum. This intersphincteric abscess lies right between those two muscle layers. And then, of course, a supralevator abscess is sitting up above the levators or the pelvic floor muscles outside of the rectum itself. It's extraperitoneal, so it's under the peritoneum, but it's sitting outside of the rectum. Those are the way I really classify abscesses in the anorectal spaces. Remember, about 50% of these abscesses are going to heal into a fistula. The only way you get this abscess is through some connection here from your glands, the cryptoglandular, or the gland structures here out into this space. So 50% of these are going to heal into a fistula. Therefore, we have to plan our incision accordingly to minimize the complex of the fistula. What I teach my residents is try to drain close to the sphincter when possible. And if it's a supralevator abscess, drain into the rectum. Just to think about the anatomy here for a second, if you have an abscess out here in that ischiorectal fossa, if you put your incision way out here, you'll potentially have quite a long abscess or quite a long fistula tract versus putting your incision here to drain this abscess. You'll have a much shorter fistula tract. If you, on the other hand, were to drain this supralevator abscess externally, come through these levator muscles, now all of a sudden you've potentially given this patient a very complicated fistula from way up here in the rectum. Presumably that's where the source is coming from through these supralevator muscles down into this ischiorectal fossa. Be very complicated and hard to treat. So draining this, just popping right through the mucosa, right through the wall of the rectum and draining this abscess right into the rectum itself really eliminates the problem. You can see the classification of the fistulas. You have extrasphincteric. Again, this would be as a result of draining that supralevator abscess through the levators. That's extrasphincteric. You have a transsphincteric fistula. This could perhaps be your ischiorectal abscess. You have intrasphincteric fistula, again, coming through those sphincter muscles, and then a suprasphincteric, something that's really come around the sphincters. And then you can have a complete extrasphincteric, something that's the perianal abscess here that really goes through your subcutaneous sphincter muscles. Important concepts here, cryptoglandular infection is the most common cause. Other scenarios to keep in mind prior to surgical intervention, of course, malignancy, so recent colonoscopy, do we have it in appropriate patients? Inflammatory bowel disease, again, just thinking about colonoscopy in patients who have symptoms of IBD. A septic complication of the leukemic patient, they have minimal surgery, drain abscess, don't incise their fistula tracts, really try to treat them as minimally as possible. And of course, a rectovaginal fistula is not included in this algorithm. This is a beast all unto itself, and really should only be taken on by experts in colorectal surgery. The treatment algorithm here, the way I think about this, if I can see the external opening on physical exam, I take the patient right to the operating room for an EUA, for exam under anesthesia. More than 50% of the internal sphincter is involved. If the answer is yes, I put in a draining ceton. I let that heal, let the drainage go away, take them back to the operating room. Sometimes we can put in a fistula plug, fibrin glue. If they're healed after that, then we celebrate. The majority will not be, and we'll have to think about some type of an endoanal flap or endorectal advancement flap, something like that. If, on the other hand, it's a fairly straightforward, less than 30% of the internal sphincter muscle involved, we can simply do a fistulotomy and curettage. The vast majority of these will heal after that procedure. If there's no external opening on physical exam, but the patients are clearly having symptoms, they're getting swelling, I'll send them off for an MRI to further delineate anatomy and then try to figure out how to treat them from there. The Fistula Plug procedure, this is a fibrin plug or some type of a plug made of some type of material that you really put in through the fistula tract itself. These heal sporadically, I'd say. The early results were they were very successful. Today, I think we're less confident that they're going to heal with a fistula plug, but it's certainly still a vital part of our treatment algorithm to try to get this fistula to heal with this plug without cutting sphincter muscle. As far as pilonidal disease goes, this is our last topic we're going to discuss here, subcutaneous infection occurring in the upper half of the gluteal cleft. It's a hair nest. The exact etiology is unclear, but it's likely an acquired condition, foreign body reaction when hair burrows through the epidermis into the dermis and subcutaneous tissue. Again, the exact etiology is unclear. Some people debate if you're born with it or if it's acquired. Not exactly clear, but the treatment is fairly straightforward regardless of how it's caused. Generally looks like this. It's somebody who's fairly hirsute. They've got some draining openings in their gluteal cleft. The treatment is fairly simple if it's simple disease. If the sinus is infected, you just have to incise and drain it. I don't do any major procedure at this point to try to prevent it from coming back. At this point, when they present with an infection, I drain the pus. If it heals as a chronic pilonidal sinus, or if they come in with a chronic draining sinus and we're going to try to do something primarily to repair the pilonidal or get rid of the pilonidal disease, you can do an excision with primary closure. The problem here is it's a difficult space to get to heal. These tend to be fairly deep problems. We often see these in morbidly obese or obese patients, and you end up with a fairly large wound. When those wounds fall apart, they heal by secondary intention, and you often end up with a bigger problem. There is increased recurrence rates, increased infection rates. Marsupialization is my own preferred technique. There's really no difference in healing rates compared to primary closure. There's a decrease in recurrence rates. The way this looks is you essentially open the tract, curette out all the hair, curette out all the granulation tissue from the tract, and close the tract down to itself, so the skin down to the base of the tract, really just marsupializing the problem. Complex is defined as extensive sinus tracts with recurrent disease. There's lots of flap procedures. The bottom line is none of these have level 1 evidence to support. There's high complication rates and recurrence rates. If you're considering these, you either better be an expert or send them to someone who is an expert in the flap generations and helping these flaps to heal. Another option is simply do a resection and vacuum therapy. My own personal algorithm here, pilonidal disease, patient presents with an abscess, I IND. I let it heal. If they recur, they have pits. If it falls into this simple category, I excise with primary closure or marsupialization. My own bias is marsupialization. If they recur after that, it's more complex. I'll send these patients off either to plastic surgery for some type of a flap procedure, or I'll do it with the plastic surgeon, or we'll consider an excision with just vac closure. So just to conclude here, these present some unique problems, and improper management really can result in terrible complications and poor quality of life. I do think there's some logical approaches that will aid in demystification of these diseases, and in general, if you'll follow these algorithms, I think it'll get you out of a lot of trouble. So thanks a lot for your time and for listening.